it's so funny because I get a lot of patients test back, and I mean, the test will look like a Christmas tree. A lot of things in the red, and the only thing that they'll focus is like, what do you think about my cholesterol? Right? And it's like,
we've been so conditioned.
Yeah, so conditioned to the cholesterol. So I don't want people to freak out if they see their cholesterol above 200. All right, guys, welcome to another episode of the Beyond Biohacking Brothers with, as usual, with my science geek and brother, Miguel, and the one and only Dr. Rudy.
The adopted one?
The adopted brother in the basement. So we wanted to give you a continuation to our last episode where we were discussing what comprehensive labs are, what are some of the contents that you should ask any doctor or any practice to run, and we explained, some of the values, and we started with the basics. We discussed things like CBC, CMP, hemoglobin A1C, and things of that nature. And on this episode, we wanted to go a little further. It took a little longer than we expected last time, so we wanted to continue it. And to get into the juicy part of the labs, which is what most clinics don't run. They typically run the safety markers, which are the CBC, CMP, and some of the, if you're doing testosterone or hormone replacement, they'll run some basic panels there. But we wanted to discuss, obviously when we're focused on longevity and human performance, we want to go really, really deep. And obviously with a safety concern always at the forefront, because we believe in the Socratic Oath, which says, do no harm.
Do no harm.
Do no
You
harm.
don't know what's the rest. Huh? You don't know the rest. What's the rest?
I don't know the rest.
I have no idea, and I know the rest. It's 3 pieces to that thing.
Are you taking the D from my MD away from me? I'm just an
That's
F now.
untakeable, man.
It's only prescribed intended medications to heal or balance out the body. Do no harm. And the third one is my favorite. Live an exemplary, professional, and personal lifestyle. Meaning if your doctor is fat and falling apart, be careful.
How many of those
Luckily, Dr. Rudy's pretty sexy, man.
Come on, baby.
I gotta admit,
He wears a
he's
slim
not a
sock
compliant
around his belly.
He's not a compliant patient, but he looks damn good. He looks damn good, man. And you know what? He beat both of us on the True Diagnostic
My
test.
dogs take more stuff than you. Literally.
But who has the best diagnostic age? I do.
No, you do.
I do.
All right, guys. With no further ado, this is where we left off. We wanted to talk about cholesterol. So cholesterol, I think, and correct me if I'm wrong, Doc, but it's the typical, and by the way, we do too, right? Like the typical clinic will run just a few panels, right? And they'll make a lot of diagnostics off of that. And I think that this is a subject that's really misunderstood. We have a few cardiologists that are patients of ours, and I've gone into great length into the discussion of cholesterol. But why don't you tell us a little bit about how you read cholesterol and what are you looking for? What are your concerns there?
Yeah. So again, cholesterol could be a whole hour.
Yeah.
We're going to try to be very simple and to the point. There is controversy about cholesterol.
Yeah.
So high cholesterol doesn't always mean heart disease, but there's a lot of correlation that higher cholesterol level may be associated with heart disease.
Right.
So a basic cholesterol level will include your total cholesterol, your HDL that we call good cholesterol, quote unquote, your triglycerides, and your LDL that we call, quote unquote, the bad cholesterol. Usually they'll have some ratios of total cholesterol to HDL, total cholesterol to LDL, give you some information. This is what most blood tests have, like the basic cholesterol. We're not going to go into detail today about if you were to do like the full breakdown, fractionated lipid profile with all the different size of the molecules. Yeah. We're going to stay with this one. Yeah. So
the usually one, that most
the basic one. There's usually, the chart will say they want your total cholesterol below 200, your LDL below 100. Those are very hard to interpret. So when I talk to a patient, I always inquire about their family history. If they have a family history of heart disease, especially if it's a first-degree family member, mom, dad, brother, sister had heart disease at an early age, whether they smoke, whether they have high blood pressure, smoking, even secondary smoking, high blood pressure, insulin resistance, weight issues. So I try to really have what is that patient 10-year risk. And there's actually a lot of calculators online that you can put all that data, and it will give you the 10-year risk of that patient for cardiovascular disease. So cholesterol plays a role in this.
Right.
So there is no question that we've seen patients with high cholesterol who've never had heart disease, a calcium score scan of 0, everything looks good despite the high cholesterol.
Yeah.
We've seen many patients with high cholesterol going to develop heart disease or stroke.
Right.
We've seen a lot of patients with normal cholesterol who then have a major heart attack or develop heart disease.
Yeah.
So cholesterol doesn't tell us the whole story, but it is a finger that points.
It's a flag.
It's definitely a flag. So if I see somebody that has a high total cholesterol, a high LDL, a low LDL, a low HDL, a high triglycerides, I already see, okay, this is a more red flag type of level.
Yeah.
What's this patient's weight? What's his family history? What's all of those other things, so I can put a picture together and decide. Another very important thing for me that I look in cholesterol in a lipid profile would be to the triglycerides to HDL ratio.
Yeah.
So that's really important, because the higher your triglycerides above 150 usually will show that there's some insulin resistance. So another very atherogenic, meaning causing plaque, lipid profile that we see is the high triglycerides above 150, above 100, and a low HDL less than 40. That's also contributes a lot to plaque.
And it's funny because and one of the messages that I want the people to walk away with that are listening to this is, it's so funny because I get a lot of patients test back, and I mean the test will look like a Christmas tree, a lot of things in the red, and the only thing that they'll focus on is like, what do you think about my cholesterol? Right? And it's like,
we've been so conditioned.
Yeah, so conditioned to the cholesterol. So I don't want people to freak out if they see their cholesterol above 200. Like, it's yes, should you look deeper? Are there other methods, like you said, calcium score and other things to look at? For sure, but nobody should be freaking out because of having cholesterol of 200. I mean, you should definitely consult with the doctor, but
let's define something, because again, there's another thing that I was looking up. I was trying to see when was the first time ever tested cholesterol, right? Commercially was in the 80s. And it used to be that under 200 was optimal. Borderline high was 200 to 239, and high was 240 and up. Now it's 200 and below. Yeah. But in addition to that is, to really see what's going on, you would have to measure the particle sizes. If you have oxidized.
Well, we're not going to go too in deep with this.
Right, but what I'm saying, there's a deeper layer to actually, what we test for gives you the signs to go deeper, but it's not the whole picture.
Right, correct.
And one more thing, that because people, the LDL, bad cholesterol, HDL, good cholesterol, let's just define that for a second quickly. LDL is the protein carrier for cholesterol that goes from the liver to the tissues. And then HDL is the one that it cleans up whatever is left of the cholesterol back into the liver, that recycling process, right? So if LDL is too high, it means that you're outputting too much cholesterol and it's oxidizing somewhere in your arteries. And that's why there has to be a good flow of that recycling
Not
system.
necessarily, because when you say oxidizing, what we're seeing exactly when you do the breakdown and you do like the deeper look, you measure oxidized LDL. And oxidized LDL depend on your inflammatory milieu, depend on your iron levels, depend on so many things. Right. So for example, what I see a lot in the clinic is first, let's say a couple of things about cholesterol. We need cholesterol.
Yeah.
Cholesterol is part of the membrane of the cell that you need that. So we see guys, people taking statin medication, and their total cholesterol is less than 120. Yeah. You cannot make testosterone.
I mean, the studies show that will lead to dementia.
Yeah, it can lead to so many things, bad outcomes. If you have heart disease already, there's no question, the studies are very strong, that the lower your LDL for secondary prevention, meaning you already had heart disease, you want your LDL as low as possible, because that's the LDL that can go and deposit. You want your HDL as high as possible. Okay. But cholesterol is needed. We need to eat good fats. We need a certain level of cholesterol. Cholesterol is also an acute phase reactant, meaning that when it goes up, it's because you have inflammation. So a lot of times when you see a cholesterol level go up, it's because there's inflammation, there's bad eating, or there's exposure to something, and that you show that. But it is a risk, because the high cholesterol long-term may be a sign that heart disease or stroke is going to happen.
And not to mention that all sex hormones, steroids in our body are cholesterol-based. So we need a healthy cholesterol level.
And just because you made the mention of it, and I definitely don't want to go down this rabbit hole because it could take an hour, but and statins, right? So the way that, and correct me if I'm wrong, the way that I see it is, like statins have proven to be, life-saving, right? So there is appropriate situations where a statin is called for. The way that I like to see it, it's kind of like, hey, if your house is on fire, you need the fire department, and you turn off the fire. Hopefully, the idea is to use it short-term by doing life modifications. Short of you having some genetic condition or familial history, but do it for a certain period, change your lifestyle so that you don't have to depend on the medication. Would you agree with that?
Yes and no. Unfortunately, there's people, for example, if you have somebody that their dad had a heart attack at 52, their uncle had heart attacks in their 60s,
Right.
that's a really strong family history.
Right.
A patient like this, I'll be a lot more inclined to put them on a statin because they have such a strong family history, which is more important even
And
than
they
the
have the
cholesterol
markers.
numbers.
They have
and if the
markers.
cholesterol is out of
Right.
range, there's something called familial hypercholesterolemia that I see a lot. That's when your LDL is above 200. I'll see an LDL of 250. The guy is lean, total cholesterol of 320. And you're like, yeah, this is most likely familial hypercholesterolemia. And with this, there's a lot of studies that show that long term, that you have a higher risk of cardiovascular disease. So, we don't have enough time to go over the whole cholesterol, but what I'm going to say, cholesterol is still an important marker.
Yeah,
it's
for
not
sure.
the only marker. You can have heart disease with completely normal levels. But if you have high levels, you want to go deeper and look what's high. And talking about this, although we don't want to do all the way, what about your LP(a)? That's a strong risk factor for heart disease. What about your ApoB? ApoB, now we know that they're checking it almost everywhere because that's more important than your LDL. What about your LPP-LA2? Big words that are like when you do the fractionation of your lipid profile, you look at all those things. What about if you have a normal cholesterol, but you have a high HSCRP, C-reactive protein? That's for inflammation. You interpret your cholesterol different depending on how much inflammation you see on the blood
And the
test.
lifestyle.
I think before we move on from that subject, let's for the listeners to really consider that, if you are going to take a statin or you need to take a statin, that you supplement with a proper supplementation, because sometimes we think these medications are magically working, but your body is a reservoir of nutrients, minerals, vitamins, antioxidants, etc. So when you use a statin, your CoQ10 levels, which is a very potent antioxidant, not only to protect you immunologically, but it protects your heart. It's for longevity, has many effects. So consider that when you are going to take medications, your body has to utilize other minerals, vitamins in your body to to give you the effects of that medication. So if you are going to get on these medications, take the proper supplementation along with it, along with a lifestyle.
And if you come
all
to
that.
me, Charlie, you have all these numbers. Trust me, we're going to talk to you about lifestyle changes.
Yeah.
Completely.
Lifestyle
And that's a
changes.
great point. A lot of patients who take statins, studies are very strong that it depletes your CoQ10 level.
Yeah.
So we usually, and a lot of
Yeah,
times
it's
the patients,
automatic for
it's the
us.
first time they hear that when we say that.
Yeah.
It's very simple. You take a statin, no problem. Make sure you take a CoQ10
yeah.
supplement with it.
Next-
Metformin
Yeah.
with B12
Yeah.
that I said before.
Yeah.
So
Also.
a lot of times medication can do something good, but deplete it somewhere else.
Yeah.
You need to work with a clinic who knows
that knows
about
what they're
it.
doing. Yeah.
Next, I think that this is also a huge one. Let's get into the thyroid, because most clinics that I've seen, when I get labs from, 98% of clinics that send us labs, you'll usually see TSH and maybe T3 or T4, maybe.
Maybe. Again, thyroid, it's a really important concept because, again, we do hormone replacement therapy, and hormone replacement, it's like an orchestra. It's like a symphony. It's not just testosterone. You need all of your supporting hormones, all of those little other instruments that are in the background to really make that amazing music. So you can't just give somebody testosterone and their thyroid hormones are not balanced. They're not going to feel well. It could be that their cortisol, there's not a great way of measuring cortisol, but or their insulin resistance. So many hormones can be out of control, and then you only replace one and the person will not get all the benefits.
I think it's important to mention that there's not a single study that shows having a healthy or normal TSH will prevent you from having subclinical hypothyroidism or some form of thyroid problem. Meaning that if you have a normal TSH, it doesn't prevent you from not having some problem with your thyroid.
Well,
right? You can
yeah,
have
but at the
normal
same
levels,
time-
but your T3 can be low, your T4 can be
Yeah,
low, and
but-
you can have subclinical hypothyroidism.
But TSH has become very sensitive. It's the third generation TSH. It's very, very sensitive.
Oh, I didn't know that. Wait,
So
what? Third generation?
Yeah, because they've refined.
Meaning our TSH is a third generation TSH?
Yeah,
or
just
all
because
TSHs?
they refined the way they check it. Now it's very, very sensitive.
Really? I
Normal
didn't know that.
TSH is about 0.5 up to 4.5. The higher your TSH, the slower your thyroid.
Mm-hmm.
So if you get a blood test, you see your TSH is 4.5, is 5.8. It will say low, high. It means you have a slow thyroid. Then you look into your free T3, free T4,
Reverse T3, TPO.
T3, the active thyroid hormone is T3. But the body, the way it is, if you take, it needs to be converted from T4 to T3 in the body. And most people, when they take hormone medication, they take levothyroxine, brand name Synthroid or other ones, spew T4. If your body's lacking the capabilities of transforming T4 to T3, then you can take all the T4 you need and you won't feel the results.
Right.
And I think to your point, when you were saying, can you have abnormal thyroid function with normal TSH? Yeah, you can,
That's
but
what I mean.
TSH is actually very sensitive. So what I go for, and the functional goal of a TSH is from 0.5 to 1.5.
Right.
Anything above 1.5, then I'm like, oh, it's not optimal.
Right.
Let me look at the free T3 and free T4.
Yeah.
Free T3 normal is 2.4 up to 4.5. We want to see a free T3 above 3.
Right.
We want to see a free T4 in the upper limit of normal.
And and going back to this whole point that you guys were going back and forth on, like my TSH was normal, my T3 was a subpar, and I started taking a very tiny dose of T3, and boom!
And
I
you
mean,
felt
my
better,
cognition,
yeah.
my brain fog, my energy was completely different, even while I was on testosterone. So, really important for the listener. Don't just settle for a TSH. Make sure that they have at least a T3 reverse, T4
Reverse
direct
T3,
T4 and reverse T3 with TPO.
And one point really
Yeah.
quick. So when we look at somebody like you, and we have a lot of those patients that are on hormone replacement, you are doing pretty well. But then at some point you said, man, I'm a little
Something's
more
wrong.
tired. I'm a little more brain fog. We tracked your free T3, and your free T3 had been consistently going down. We don't know why.
Yeah.
But once we replace just T3, liothyronine,
Yeah.
you felt so much better
much
with
better.
it. And we have a lot of patients that if we see, some patients come to us, they're like, I need more testosterone. I'm not optimized. Your level is 1200. I need more. Let's take a minute. Let's take, is your thyroid good? Is anything going on? And T3, so, sometimes you take supplements, you take medication and you don't feel any difference. The medication, you will feel a difference.
Yeah.
Thyroid will make you feel better.
Big time.
If you're deficient. Testosterone will make you feel better. You'll know you'll take it.
feel like hormones that you actually
If you
feel
take
them.
vitamin D,
You're not going to feel it.
You don't feel it.
But
It's
it doesn't
behind
mean
the
that
scene.
it's behind the scene.
But thyroid makes you feel good. So everybody going on that route of hormone replacement, check your free T3. Check your TSH, make sure it's between 0.5 and 1.5. And the other test we checked also, TPO, thyroid peroxidase antibodies. That is positive when you have Hashimoto's hypothyroidism.
Which is like 70% of all
75% of all
hypothyroid,
hypothyroidism. A lot of patients will come to us. I'm like, did you know you have, you've been taking Synthroid for 10 years.
Yeah.
We checked your labs, you have Hashimoto's. They're like, what is this? I never heard this. And to me, it's important because there are supplements you can give some nutritional advice, avoid gluten, avoid dairy. Hashimoto's tends to get better with this.
Well, I had one more point. This is to geek out some other day. But
right.
for example, when you talk about levothyroxine, people taking T4. So we produce 4 times the amount of T4 than T3, but ultimately what we need, the fuel that we need is T3. Now, I have a genetic disposition where my DLS2, which is a thyroid gene, which converts 80% of your T4 into T3, is dysfunctional. I have a double copy. It means that gene is broken.
Explains it.
So I have to take T3. So I'm just thinking of patients who the majority of PCPs, primary care physicians, will prescribe T4. But what happens if you have this genetic variation like me? You're not converting as well, and they still have the lagging issue.
So the great points here. First, man, our next big thing we're going to do is we're going to go full force into genomics to really understand everybody.
We got to educate first our listeners. We got to upgrade them.
Educate even ourselves. It's so big, but we're doing a lot of studies about on the right path. So really important. Most primary care physician endocrinologists, if you have hypothyroidism, the standard of care is T4, levothyroxine. And most studies. the studies that I used to see in medical school, they
all
only
practice.
use, that's all they use. So they use
All practice.
desiccated thyroid, like things like almond thyroid way back. Then they make synthetic T4 and they're like, that's much better. But when you look at it, like it's better to use desiccated thyroid supplement that has T4, T3, it has iodine, it has all the entourage effect of everything that your body needs.
And it's from pigs, right? It's like 99% identical to what we produce.
To what we produce. And so the studies, again, conventional medicine only use T4. I remember seeing a few studies that like, maybe there's 1 or 2% of patients who may not feel well enough with the T4. Okay, to try T3 combination. The average endocrinologist doesn't even believe in that. They're like,
crazy.
all you need is T4. They don't even check T3. But again, endocrinology should be a symptom-based specialty.
Which that's
So
always
that's
blowing
what
my
we do.
mind. Endocrinologists, you study hormones and endocrine
And then
glands,
you
and you
look
don't
at the
like.
By the way,
numbers,
they're
I
the
know.
worst. When we
They
when,
are
when
the
we get
worst,
labs
man.
from endocrinologists, they're the worst labs.
Yeah,
ever.
yeah.
I have
It's
some good
terrible.
endocrinologist friends who are good, but a lot of them
they're
really,
just-
they're too within the book. Endocrinology should be a system. So your example is a really good example. I had seen your free T3 at 3.2, 2.9 sometimes,
2.7.
but you felt good.
Yeah.
So there was no reason to address it. When you started not feeling optimized, you were like, okay, let's take a deeper look. And we're like, okay, it may not be your testosterone. Your T3 is not optimized. And then we did a therapeutic trial of T3.
Super low dose.
And then you super low dose, very well tolerated, and you did amazing. And that's a lot of our patients. Actually, fun fact, T3 is one of the few medication that is FDA approved without even having a blood test. So T3 is FDA
So
approved
if
to
you find
relieve
symptoms, just based on symptoms, you can
symptoms
prescribe
of
it.
depression. So it is, if you have
that's
symptoms
right,
of
yeah.
depression, it is an FDA approved medication to try without even checking numbers. So
Interesting.
that's how much. And then
That's how we should do all things.
how come, like, so then you come to me, why wouldn't I ask you, okay, do you have brain fog, low mood, anxiety? And I need to put low T3 in my differential diagnosis. It's even FDA approved, but the average clinic, the average provider doesn't do this.
All right, so let's move on. This is a big one because it's connected to B12, and you guys have all heard big names talk about this molecule, this marker, homocysteine. So homocysteine obviously marks for the moment that we see it. First of all, just by itself, we see inflammation in the body, right? And if we see low levels of B12, now it's another red flag that you might have a genetic mutation, MTHFR, which we'll do a whole section on that. But homocysteine is a super important marker. I mean, when you see high homocysteine, what do you look at? What do you see?
So the homocysteine basically is, again, not every clinic checks for it. So if you have, the big buzzword now is MTHFR mutation. And if
Which
you
is
have,
real.
Yeah, it happens. I have a double copy of the MTHFR.
All three of us have a double copy.
We all have it.
You have the one, the C677T?
Yeah, no, the 1298. I'm homozygous.
we have the 81298T.
So I'm homozygous on the 1298, and my homocysteine level at one point was 37.
I never had seen
It was
that.
one
I
of the
remember that.
highest homocysteine I've seen. I'm not sure why. So again, we so far we don't usually check for an MTHFR. We look for the phenotype. Do you actually, because you can have an MTHFR mutation, you have a normal homocysteine, it may not be causing a problem. But if you have a high homocysteine, it means there's a backup in the system, and then you accumulate methionine. You don't have a good conversion from methionine to cysteine. So it's a pretty complicated.
That's
You want me to tell it to you real fast? I can geek you.
Don't geek
don't
out
do
on
that.
this.
No, I'm
It's-
not.
Wait,
It's
hold
simple.
on.
It's simple.
It's so that the listener kind of just.
Yes.
It's basically the analogy that I love to use, and we use this all the time.
I love you guys.
It's like saying, hey, you wouldn't put crude oil into your gas tank. You need refined gasoline. So when we see high homocysteine, what that tells us is that your body lacks the ability to take raw nutrients, whether that's supplements or food, and turn them into their energetic equivalent. Right? Is that sort of explain it?
So
Let the geek go
the geek-
over it. We give
Come
you
on, Gil,
45
let me
seconds.
explain you. So the buildup of homocysteine obviously is an inflammatory marker and increases your chances of cardiovascular disease or cardiovascular risk in general. But what people need to understand is when you build homocysteine, it means you're not methylating it back into methionine. And methionine, actually, I did a lot of research on it, really does happen to be the initiator for protein synthesis, not for all proteins, but for a lot of proteins, it initiates that protein cycle. So another thing that it does when you have high homocysteine, it scars the inner lining of your blood vessels, affecting your nitric oxide productions. And if you scar your blood blood vessels and they start to collapse in a fixed system, pressure goes up. So you can even have blood pressure issues.
That's the risk of cardiovascular disease, increased blood pressure.
That was a good explanation.
Yeah, and also a lot what we see with MTHFR high homocysteine, it's like nervous things, anxiety,
Well, no, I
sleep,
have it. I remember.
psychosis.
Yeah.
You have all that,
I have
bro.
all that stuff. Well, I test my methylation circuit and I got a break at the beginning and at the end. And so it's MTHFR, MTR, MTRR, AHTY, and COMT. So I have a double copy of the
Raggedy garden
MTHFR,
hose.
the COMT, and AHTY, which are more for the brain. So what I would say, we have a product called homocysteine factor that has, so for MTHFR, you use tetrahydromethylfolate, which is for the MTHFR. Trimethylglycerine treats more the neurocognitive issues. That's why you see me calmer and more cooler. But there is ways to treat it. Okay.
All right.
And the big thing when we see a homocysteine, you need, and you have a lower level of B12, you need methyl
Methyl-
B12,
methyl-
methylcobalamin.
Methylated B12.
And that's why you'll hear some people say, oh, they give you cyanocobalamin,
Cyanocobalamin.
oxycobalamin at that clinic. They don't know what they're doing. If you don't have an MTHFR mutation, it's okay to take those other ones. But if you don't know, it's better to take methyl. So we all take methyl B12 because we
vitamin.
all have the MTHFR mutation.
All right, the big one, and I'll say these all together because I think that any practitioner who is going to use hormone replacement, specifically testosterone for either men or women, I mean, aside from the prostate level that I'm going to talk about, I mean, if you don't read these these 5 markers, I don't think you can make a proper diagnosis on low T or whether someone needs low T.
what are those 5 markers?
So it's prostate, it's total testosterone, free testosterone, LH, FSH, sex hormone binding globulin, and estradiol. Actually, that's 7. Sorry.
Well, the prostate, the PSA, we won't put it on this. The PSA.
Well, the PSA is more like, hey, I'm not
Yeah.
going to put you on testosterone if you have a PSA of 4.
Yeah.
Like, that's it's a safety marker.
Yeah, but when it comes to the testosterone, and I think that's what we're going to spend the last 10 minutes because that's our bread and butter.
Yeah.
So you need all of those markers. So if you go and you ask your doctor, Doc, I feel tired.
My sex drive is
My
down.
sex drive is
mental
down.
fog,
I think,
depression.
can you please check my testosterone? First, you have to beg for this. It's usually not included.
Yeah.
The doctors, we see that all the time. The patient told me, and I'll never forget that. He's like, the doctor told me I have every symptoms of low T. He told me I have a full beard. You cannot have this low testosterone.
Wow.
But let's
Are you
clear
serious?
this up because this is what I explain a lot of times to patients is a lot of times doctors won't do it because whatever they test for, they're liable for it. And if they don't know how to read and do anything with that test and something happens to the patient, it's their butt on the line. So I feel like there's a lot of kickback because they don't know what to do with it, right? So
And also because, I was trained, doctors were trained that low testosterone happens in your later years. So why would we check? So I think there's a disconnect in the medical community realizing that we have a true epidemic of low testosterone happening to your young men, to our men in general, happening to women also.
Yeah, big time.
Low testosterone in women in premenopause, high testosterone at early age. The toxin environment is really wreaking havoc on our system. So let's go over this. So testosterone, number 1.
Yes.
Total testosterone, it's a joke how the reference has changed. So back in 2007, the normal testosterone at LabCorp was 300 to 1200. The 300 was an arbitrary number that they just decided. The Urology Association said
a round number.
that's a round number for the low number. I don't know how they came up with the 1200, but it's a round number. It's very suspicious. In 2017, they did a study. LabCorp did like a big took a bunch of patients. I think they took about 25,000 men between the age of 19 and 40 and took an average. It's not a physiological number, it's an average.
They cut the top 5% and bottom 5%.
Yeah, and then they say
run
this
the
is
average.
where it should run. And that new number at LabCorp is 264 to 916. So that's why now if you have a patient who has a total testosterone of 280, goes to see an endocrinologist, they'll tell him, your
you're
level's
low,
normal.
normal.
You're kind of low, but you're normal. And that's why when our patients go see them, they have a testosterone of 1,000. They're like, that's way too high for me. So total testosterone is important. We follow that, but it's not the only one.
Here's the funny part, because I actually looked it up on LabCorp. Their lab ranges for total testosterone used to be 300 to 1,000 back in 2000. 2010, they brought it up to 300 to 1,197. And in 2020, 17, they brought it down to 900.
So when people say supraphysiologic testosterone level, we don't know what the physiologic testosterone levels are. All we have is an average. It's a mean. You take a bunch of people, you see what their numbers, and you take the average.
I mean, I would say
That should not be-
supraphysiologic, the level comes back at 6,000.
Yeah,
right?
but
Like
yeah.
that's
we
a
know
bodybuilder.
that's too much.
And even then, you don't know because the LabCorp cuts it off at 1,500. So you
Yeah, no, but there's some labs that measure it. I
But
saw a guy at
for the
4,000.
sake of discussion, for the average listener to know, just know that total testosterone tells you very, very little about what's actually going on. So why don't we move down the list?
Not necessarily. It gives you a good amount of information,
Right.
but it's not the only thing.
It's not the only thing,
Because again, those are like, it has what we call a positive predictive value.
Right.
If it's low, or you have low T.
Yeah.
If it's normal, you could still have low T. But if it's low, you have low T. So it's really good if it's abnormal.
No, and on the contrary, let's say you have a guy that he does follow up blood where he comes at 2,200, right? Whatever. Let's say the lab actually measures it. And he tells you, Doc, I'm still feeling depressed, fatigue. Well, then let's check something else because it may not be the testosterone anymore, right?
So it has value. But then we walk
That's
into
a value.
the
It's not the
free-
end all be all. That's what I meant.
Then you need the free testosterone.
Yes.
We always check free testosterone. The average primary care doctor, urologist don't test that because it's not usually covered by insurance. The way I like to explain total versus
Wait,
free,
you're not covered by insurance?
most insurances don't
Wow.
cover it.
They do not.
I
Interesting.
think some are starting to because I see some of our urologists referrals now because urologists do send us patients.
Yes, they do.
The patients they don't want to deal with that are asking them too many questions. They send us those patients. I love that.
I love that. Bring them
So
on.
total testosterone is money in your savings account. Free testosterone is cash in your hands. So what I tell my patients, I don't care that you have 600 of total testosterone. Great, you have a great savings account. You are the farmer's market. You need cash.
Yeah.
Where's your free testosterone?
Yeah.
If you have a free testosterone normally is from, depending on the scale, from 7 up to 30, 35. So if you have somebody who comes in, we have this, a total testosterone of 500, a free testosterone of 6. You have low T if you have symptoms. So we put together
Well,
symptoms.
you know what's funny? Let's use this lab marker right here. So this patient has a level of testosterone at he's let me see how old he is. He's in his early 50s. He has a total testosterone of 350. So most doctors would tell him you're
good.
absolutely fine, but his free testosterone is 4.4, which is below the range.
Yeah.
And that's, I mean, when we see something
4.4.
below the range, we are like, dude, you're super low.
And I remember this patient well. He was so relieved that he saw something low because he went to his doctor, all the symptoms. I'm tired, I'm depressed, my libido's down, I have belly fat, I don't feel like
ED.
doing anything.
All that.
He's like, I think I have low T, 350. The doctor told him, no, it's kind of good still. We want 1,000. But when he came to our office and we did the free testosterone, it's like, I'm not crazy. Something is low in my numbers. And this guy now is thriving.
Flying.
He's killing it.
Yeah.
So a free testosterone of 4.4, you're cash poor. You cannot mobilize your total testosterone to be used. So this is where total testosterone is almost useless. Doesn't matter how much total you have, you need the free. And then you look at the LH, the luteinizing hormone, very important. That's how we determine whether it's primary versus secondary hypogonadism.
Or
Doesn't-
functional. Or functional.
Exactly. You determine that. If you have a
And by the way, let me just explain that for a second because I love that you do that. Because most people that I've seen that go to a TRT clinic or whatever, they don't actually get a diagnostics of what kind of low T do they have. I love that you separate it into primary, secondary, and functional.
And even now he has partial androgen sensitivity or
primary
hyperandrogen
compensated,
resistance.
primary compensated hypogonadism.
Damn, what the hell?
on your
Like, keep
toes,
putting out
baby.
some weird ass
you know,
terms.
the reason why Doc does that, and just for the average listener, we're not going to go too deep on this, but just know that you want an actual diagnostic to what is going on, and that's where you see the diagnosis. About the relationship between testosterone, free testosterone, LH, and FSH, which are your natural, your markers for natural production of testosterone in sperm.
Yeah. So if you have a high LH, LH again goes from the pituitary and tells your testicles to make testosterone. A high LH shows that there's a damage to the testicular cells. So that's what we call primary hypogonadism. Things we can see if you've had trauma to the testicles, if you had mumps. Mumps is one of the viral disease of childhood that can affect your testicular function. If you've had radiation to the testicles, Sometimes now we're seeing that some EDCs can directly be cytotoxic to the testicles. And you'll see a low testosterone with a high LH. That's primary. What's important with primary, those patients will not respond to HCG or Clomid. So if you see a patient who has a high LH and a low testosterone, don't even try using HCG.
Which again, this is why it's so important to get a full, that's why I said all these markers together, because so many people be like, well, let's do a therapeutic trial of HCG, and they didn't check their LH and FSH. How do you know? You're not going to respond. So you just wasted the patient's time, money, and you frustrated them.
So the other one is when you have a low testosterone with a normal or low level of LH. That's called secondary hypogonadism. Usually it's not anything wrong with the testicular function. It's with the pituitary. That's not sending the signal to make more testosterone. That's the more common form of low testosterone hypogonadism that we see. And there's many causes. It's just your pituitary doesn't send the signal. Aging is number one that causes that.
Iron
causes that. EDCs causes that. Stress and high cortisol cause that. This is the more common one. That's what we see mostly.
In older adults or younger adults?
Both older and younger, because in older, age is one definitely a risk factor to decrease your LH. But in a lot of our young men, what we're seeing in a lot of our young men, secondary hypogonadism, their LH is still pretty low. They have high SHBG, sex hormone binding globulin, that binds a lot of your total testosterone and leaves no free testosterone. So those high SHBG patients with low, those you can do a trial of HCG and Clomid. And if the patient is young, a good amount of them will respond. It may not be forever, but sometimes they get a good response. We don't have great results with Clomid and Clomiphene, HCG. We use them, but as a monotherapy, definitely not the best.
But this is an interesting point because, again, this is why I said all these markers together. Because, for example, Miguel and I have really high sex hormone binding globulin. That means that we a lot of our total testosterone is bounded to this hormone called sex hormone binding globulin, and we don't know exactly why this happens. We don't know exactly why this happens, but it does.
Floating depth cord.
Right. So, the final message to that is that while somebody that doesn't have high sex hormone binding globulin will do well on a testosterone range between 900 and 1,000, for sake of discussion, Miguel and I need to run it 1,200 and above in order to feel the same effect because of the sex hormone binding globulin. So when you go to your doctor and he doesn't check sex hormone binding globulin, he might see, I see it all the time, total testosterone 900, but low free testosterone. So if then you check the sex hormone binding globulin, and it tells you the story on why you have low testosterone.
For example, my testosterone usually runs at 1,800, but I get a free T of 20. Could I go higher based on the free T that we like to see? Sure, but I feel good enough, and I don't want to run the risk of more DHC or gyno, which is the aromatization, which I have both issues.
So again, for the listener, man, this is such a complicated subject. We're trying to, I know it's long, we talk a lot, but we want people to understand that, to really kind of, if you're going to go down that path, you really need, what do I call it? Your BHD, your biohacker degree.
There you go.
Right? Because you need to understand
BHD
this.
degree.
Because if not, you will go from doctor to doctor and you'll just take their word, even my word. Don't just take it. I will teach you as a patient to even be able to challenge me sometimes because this is your health. I always say that you need to become your own chief medical officer. You need to learn enough that you can have an intelligent conversation about your health, no matter what you do in life, no matter what your specialty is, because your body is your temple. It's the only one we have.
Amen to that.
Right.
For the listener, I think that we will cut it off. We left off a few markers that are important. Maybe we'll come from at another time.
Enough.
I think they got enough. One of the things that I wanted to get into, and I just got an idea for another episode, which we will talk about the importance of estrogen and DHT, because there's a lot of companies, I won't mention any names, that are selling you, estrogen blockers and DHT blockers, which are two of the main benefits that testosterone delivers when you take the TRT. So maybe
that's going to be a full episode.
Maybe we'll do a full episode on that, but just because I don't want to leave the patients hanging, you need estrogen, guys. You need estrogen. We want it. So
in a healthy ratio.
So nobody, don't let anybody tell you that you need to kill your estrogen.
Well, remember, The way that you decrease your estrogen is by using a chemotherapy agent called anastrozole or
What we call
tamoxifen.
AKA an estrogen blocker. You're in a chemotherapy drug,
it's
buddy.
chemotherapy.
That was an MD telling you this.
All right. So that's going to come for another episode.
All right.
All right, guys. I'm having fun, man. This is great, guys.
All right, guys. Well, listen, anybody who enjoyed this, I mean, and if you have any questions or you have any topics that you'd like us to discuss on a different episode, please make the request. We're always looking for new ideas. But until then, please make sure to follow us.
Download, share this
all of that stuff. We're not very
podcast,
technologically
baby.
advanced, but it enables us to help more people and give people the truth. So until then, stay healthy
And God bless. God bless.